All right, well, I think we'll get started. Welcome, everyone. Thank you so much for taking the time to join us today. My name is Jillian McConnell, and I am a knowledge broker with Brain Exchange. And on behalf of my colleagues from the MS Society of Canada, we welcome you, and we are very pleased to have you able to join us today on today's webinar. Before we begin, I do want to take a few moments just to review the technology we'll be using this afternoon. The audio is provided over the phone, which means if you're hearing my voice, then you're in the right place. And the visual or the presentation slides are provided by the online link that you should have received in the connection details, and that way you can watch the slides as our presenters speak. On the bottom left of your screen, you'll see a little blue bubble, and if you move your cursor or your mouse over that, you'll see a chat with a presenter box. And if you click on it, that's the chat pod, and it should appear. And that's how you can communicate with me during the Q&A and as well as during the event. I do want to note that only the presenters and I can see the notes in the chat pod, not your fellow participants. And as I alluded to, that's also where you can send your questions during the Q&A portion. I do want to let you know that all of your lines have been muted for this webinar, and that just helps us minimize background noise or codes going off, dogs barking, private conversations. If you do need to ask a question or you have a concern, then please use the chat bot, as I won't, of course, be able to hear you. The presentation itself is being recorded, so within a week or so it will be available on the MS Society of Canada's website as well as the Brain Exchange website. All of you will also receive notification via email when that recording is ready and how to access it. So for the purpose of today, those are the only features you need to be familiar with. The webinar is scheduled to be 60 minutes in length, and our presenters will speak for about 40 minutes or so total, and then we'll have the remaining time, about 20 minutes at the end for some Q&A and discussion. I do ask that people refrain from asking questions in the chat pod until the end of the discussion, or end of the presentation portion, unless, of course, the question is technology related, and then I'll do my best to help you out. Okay, so now that the technical aspects have been taken care of, I do want to take this opportunity to review a few bits of information that the MS Society of Canada has asked that I share with you on their behalf. So we just want to let you know that this webinar is made possible by Shoppers Love You, which is a leader in supporting the health of Canadian women living with MS. Through which Shoppers Love You initiative, Shoppers Drug Mart has a commitment to positively impact women's health and MS, helping the MS Society update and create new resources and raise awareness of topics related to women's health. And of course, just wanted to point out that the MS Society does not approve, endorse, or recommend any specific product or therapy, but provides information to assist individuals in making their own decisions, and that the identification of needs, determination of objectives, selection of content and speakers, educational methods, and materials are the sole responsibility of the MS staff and advisors. Okay, so it's now my pleasure to introduce our webinar topic and presenters for today's event. So today we will be discussing pregnancy and multiple sclerosis, and we are so pleased to have Dr. Dessa Sadovnick and Ms. Rebecca Scott-Rawn with us today to present. So Dr. Sadovnick is a professor of medical genetics and neurology at the University of British Columbia. She was the director of the MS Western Pacific Research and Training Center, a Michael Smith Distinguished Scholar, an awardee of the MS Society of Canada National Award of Merit, and an awardee of the Multiple Sclerosis Society of Canada Women Against MS Award. Dr. Sadovnick has been the principal investigator of several multi-center Canadian and international collaborative research projects on multiple sclerosis and pediatric multiple sclerosis, as well as dementia. And she currently leads the CANPREG-MS study, a Canada-wide prospective study on women with MS who are pregnant or are planning a pregnancy. Dr. Sadovnick was also a developer and then co-director of the Genetic Counseling Training Program at the University of British Columbia, and she has published extensively and serves as a reviewer for a wide variety of medical journals and grant review panels. Dr. Sadovnick is a member of several national and international advisory groups and task forces for MS and dementia. And Ms. Rebecca Scott-Rawn is a communication and coaching expert. Rebecca strives to empower people to achieve their impossible with support, coaching, and laughter when they need it. She has served on the boards of Equal Voice, a multi-partisan organization dedicated to electing more women to public office, the Ontario Long-Term Care Association, and the Multiple Sclerosis Society. Having spent countless hours working with seniors, she's taken to heart the advice of those who have been there and done that, creating meaningful connections, live the life that's right for you, and have no regrets. Her favorite thing to do is to spend time with her 2 daughters and her husband in their hometown of Orangeville, Ontario. So we will begin with, first of all, we welcome both of our presenters today. We're going to begin with Dr. Sadovnick and her presentation on reproduction and multiple sclerosis. So Dr. Sadovnick, the floor is yours, and just a reminder, you can press *7, Dr. Sadovnick, to unmute your line.
Thank you. Today I'll be talking on multiple sclerosis and pregnancy. I just want to iterate that this is a very important topic not only for women, but also for fathers who have MS. Some of the issues I'll discuss are relevant to mothers, some are relevant to fathers, and some are relevant to both. However, unfortunately, the study I will be presenting today only deals with women, and that is because of funding issues, no other reason. As you can see by this slide, there are very many issues that you have to think about if you're thinking about having a child and if you're a parent with MS. You see various topics here, and these include fertilization, conception, gestation, in other words, the period while you're pregnant. There are issues specific for the MS mother, issues specific for the MS father. There are issues concerning pregnancy loss. For live births, you have to think of issues related to the mother, including resumption of therapy and breastfeeding, issues related to mothers or fathers, including relapses, parental ability to raise a child, spouse-family support, postpartum depression, and even for a child, you have to think about issues such as possible adverse birth outcomes because of exposure to any therapy, perhaps psychological aspects dealing with having a parent with a chronic disease. So these are a lot of topics, and unfortunately to date, we really don't have what's called evidence-based population data for any of these topics. The situation today is very different than it's been in the past. In the past, when a woman had MS, she was often told not to have children. Then it progressed to the fact that there was a very long lag time from the clinical onset of symptoms until a person was actually diagnosed. So people often had years before they were diagnosed, and many of them embarked on pregnancies not knowing they had a diagnosis of MS. Today we're in a very different situation. Pregnancies can be planned or unplanned. As I said previously, the lag time from onset to diagnosis can now be as short as a few weeks or a few months even. Because we're making an earlier diagnosis, people are younger and healthier. And in this day and age as well, we're into the era of informed consent, where you take the best available information and make a decision, whether it's about reproduction, whether it's about management of your disease, or anything else. No longer is it the physician says something and you automatically adhere to it. So there are various topics that need to be addressed in the future using evidence-based data, and these are the topics that we're trying to answer in our ongoing work. The first, effects of MS on pregnancy, and this is relevant for both women when they're carrying. Effects of pregnancy on MS, again, is more relevant for women. You have the short and long-term effects, but you can't forget about fathers. For example, if fatigue is an issue and there is usual fatigue just having a newborn in the house, this could affect the fathers as well. Although MS does not have a high risk to be in different family members, there is a slight chance that the risk could be that the child could develop MS in the future. And in some families where there are multiple cases in that family, this is something to talk about. We also worry about heterogeneity of MS treatments. In other words, will the treatment or exposure to the treatment at conception, during delivery, or even during breastfeeding affect the developing fetus, the child? These types of treatments range from symptom-specific, relapse-specific, and of course the disease-modifying therapies. You also have to think about the long-term pregnancy outcome. Evidence at the moment does not seem to show that if you have a pregnancy or don't have a pregnancy, your long-term outcome in terms of disability will be any different, and hopefully our data will continue to support this. There are, of course, psychosocial issues included with having a pregnancy and raising a child when a parent has MS, and there's also the consideration of long-term parenthood. But again, the concept is that you have to have the informed information on which you can make your decision. And everybody's decision is an individual decision. Nobody is telling you what to do. So the study we are promoting right now is Canada-wide. It's a 5-year study, and it's the Canadian MS Pregnancy Prospective Cohort Study, which we lovingly call CANPREG-MS. I'm the principal investigator. My study coordinator is Maria Criscioli, and I have contact numbers if anybody is interested in participating in the study or wants more information on this slide, and they will come up again on the final slide. Again, just to reiterate, when we're talking about planning a pregnancy and being pregnant, we're not talking about one point in time. As you can see on this slide, you start off with the people who are thinking about having a baby. Then, if they're fortunate and become pregnant, you have the issue during the gestation or the pregnancy. Then you have the issue with the baby being born. Hopefully everything goes well and it's healthy. And then, even once the baby's born, you want to follow development as the child develops. A lot of people have said to us we participate in the study because we feel that there's just a lack of information and we want to help get more information. This quote, I think, represents what a lot of our participants say. I'm interested in enrolling in your study. Believe that the outcomes of this study will help many women with MS who are planning a pregnancy, going through one, and the postpartum. It is very daunting, and I wish there was more information available to assist me. Now, some of you may have had pregnancies in the past, and you may have been on a clinical trial, and you might be aware that there are therapy-specific pharma pregnancy registries. This is the situation when you're on a clinical trial, you are taking a certain drug, you're usually advised not to become pregnant, but pregnancies do happen, and therefore they monitor what happens to you while you're pregnant and if the pregnancy is successful or not. However, many things can affect pregnancy outcome, not just the fact whether or not you're on a disease-modifying therapy. And these therapy-specific registries ignore many important facts. These include maternal age, previous pregnancy history, family history, ethnicity, medications in addition to a specific DMT, including social medications such as street medications, comorbidities including gynecological, access to medical care for pregnant women, method of delivery, whether it's home, hospital, natural, C-section, prenatal screening, and long-term child development. So today we're in the real world, and we know that DMTs are available outside of clinical trials. Therefore, people who are taking DMTs and become pregnant are not monitored as closely as they would be if they were in a clinical trial. We're not excluding anybody, as many clinical trials do. In other words, you don't have to have a certain type of MS or a certain duration or a certain EDSS to be allowed to become pregnant in the real world. Everybody can become pregnant if they want to, so it's a much wider population. Again, all women are included in our study, regardless of the course, duration, disability. We know generics are becoming available, and these have to be included in studies also. We can't ignore the fact that many people take over-the-counter or OTC therapies for specific symptoms. And these can include everything from vitamins to dietary extremes, and all this has to be considered. And of course, pregnancies are not always planned. You have the planned and the unplanned. So this is our real situation today that we're trying to get evidence-based data to understand. Our study is a self-ascertainment study. That means that we advertise that the study exists, and we ask women who are pregnant or considering a pregnancy to call us by email or on a dedicated 1-800 number. I'll give these at the end. And we're also continuously advertising the study through our Canadian network of MS clinics, which has over 70 neurologists across Canada, the MS Society of Canada research portal, community neurologists who are not necessarily in a clinic setting, but often in more rural settings, public advertisements, and social media, including Facebook and Twitter. The long-term goal of our study is to learn how often do women have issues with conception, are there MS-related problems during pregnancy, what are pregnancy outcomes taking into account factors such as MS type, MS course, disease-modifying therapy exposure, duration of the disease, etc. We also are interested in breastfeeding and when the resumption of DMT does occur. We will use this information to develop a patient educational resource that is responsive to concerns of women with MS and will help the women and their families make the personal decision about whether or not to have a pregnancy if a mother has MS. And again, I want to stress this is a personal decision for every individual. To be eligible for the study, you have to be a pregnant woman with MS who lives in Canada, or you have to be a woman thinking about a pregnancy. Thinking about a pregnancy means that you're eligible as soon as you speak to your neurologist about the possibility of becoming pregnant. This could be months before you actually try to conceive. Women are eligible even if there are steps needed over the next few months, such as MRIs, reduction of medication, before the woman can try to conceive. This is critical, as we expect and have also come across. There are cases when women do plan to conceive, and yet because of various issues, such as need for special medication, they have had to delay this decision. Again, this gives us a real-world scenario. So I want to thank you all, merci, for listening to this webinar. For more information on our work or to volunteer for the study, you have our 1-800 number, which is a dedicated line for the study, and it is toll-free. And you also have our study-specific email, which again is also a dedicated email. All this is confidential. If you contact us, then usually what happens within a couple of days, you will be phoned or emailed back by the study coordinator, Maria Criscioli. She will get your information, and we will move forward from there. So in conclusion, I have no conflicts to report. This study is funded by Biogen. The ongoing assistance of UBC study personnel, Irene Yee, Maria Criscioli, and Kevin Atkins is gratefully acknowledged. But of course, the study would not be possible without all of you out there who are willing to be participants. So I thank you very much.
Thank you so much, Dr. Sadovnick. We're going to immediately move on to Rebecca Scott-Rawn, our other presenter, and then we'll field some questions after both presenters have spoken. So Rebecca, I'll turn the floor over to you.
Great. Thanks so much, Jillian, and thank you, Dr. Sadovnick. Sounds like a very interesting and certainly important study. And the information you're going to get out of there is something I think would have been very helpful for me to have a look at before I had my kids. So thanks so much for having the opportunity to speak with you all. I'm looking forward to just taking a few minutes and telling you just a bit about my experience of pregnancy and MS. So Jillian provided a bit of an overview, sort of my biography. I will just share a little bit more about myself. This is a picture of some of the things that I use to introduce myself, and most importantly there, you'll see at the bottom is a picture of my family. I do have 2 children, and I was diagnosed with MS about 7 years ago when I was 32, and have had my 2 kids since then. So, hopefully my experience can help some of you who are maybe thinking about getting pregnant or who have had the experience. Hopefully this can just give a little bit insight to you about what it could be like, and also really looking forward to answering some questions. So, as I said, I was diagnosed with MS when I was 32. My husband and I were engaged at the time, and we got married the year after. And we had a decision to make about whether or not we wanted to have children, and what we wanted to do with regards to my MS and having kids. I went on to Copaxone. I made the decision with my husband that I should go on to Copaxone first, was the first disease-modifying therapy that I used. What he said is we needed to take care of the mothership, so I went on to Copaxone to stabilize my disease before we decided to try to get pregnant. I started on a Copaxone in January 2013 and had a really good year on the drug, felt really stable, felt really strong, and decided to go off it at the beginning of January 2014. For a variety of reasons, I expected that it would take me quite some time to get pregnant if I had the ability to get pregnant at all. So I expected that I would have some time. My doctor had told me that I should probably have 3 months to get the Copaxone out of my system before I got pregnant. Lo and behold, and probably because my expectations weren't so great, I got pregnant within a month. And so we found out in early February, actually mid-February, I guess, found out that I was pregnant. So when you think about planned and unplanned pregnancies, I guess it was planned-ish. We had thought about it, and it happened a little bit quicker than we thought, which was a great, we were obviously very happy about that. So when I was pregnant with my first child, I wanted to use a midwife. I had just moved to a smallish town and got in touch with the midwives as soon as I found out I was pregnant. And unfortunately, the midwife told me that they wouldn't be able to take me on because I was deemed high risk because of my MS. That was actually really hard for me because I didn't consider myself high risk at all. I'd been feeling really well. I was expecting to have a healthy pregnancy. So it was quite upsetting to find out that I was considered high risk. I was able to Google an OBGYN, and as I mentioned, I was in sort of a small town, so there were only 2, and I went to go see the one with the best reviews, and he was really great. He was really good about my MS. He didn't have any concerns at all, and that certainly put me at ease. You'll see here in my slide, you may be able to ascertain that my first pregnancy was pretty rough. I was very sick. I threw up a lot. That's a picture of me on the right-hand side there with my niece. I actually got quite large as well with my first pregnancy. I wouldn't say that I took particularly good care of myself. It was really hard because I was working a lot. I was traveling a lot. I was spending a lot of time in the car. And I actually had to take to having an extra pair of clothes in the car, some paper towels, and some stain removers because I was actually getting sick so frequently. My job is really demanding, as I said, and I didn't make a lot of time for physical activity, which I don't think helped me very much. I also was diagnosed with gestational diabetes. That meant that I had to monitor my blood sugar and cut out a lot of refined sugars and carbohydrates. That was pretty rough on me, especially because I was 9 months pregnant on Halloween, and I wasn't able to enjoy any of the candy. That was pretty difficult. My doctor decided to induce me a few days before my due date because he was worried about the baby getting too big, which can happen with gestational diabetes. And when I talked to my doctor about my birth plan, I was pretty adamant about the fact that I did not want to have an epidural. And part of that reasoning was because of my MS. One of the things that happens with my flare-ups is that I lose the feeling in my legs, and I didn't want to intentionally, have somebody give me something that would make me lose the feeling in my body. So I was making my plan so that I could have a drug-free, or as I came to know it, a natural birth. I will tell you, though, that after 20 hours of labor, I did finally relent and actually begged the doctor to give me an epidural. And another 10, 12 hours after that, my first daughter was born. It was, all in all, not a bad delivery. I wouldn't say that my MS really had any impact at all. And at the end of it, I came through with a beautiful daughter who was born on November 7th, 2014, and her name is Clara-Mae, and there are some pictures of her there. And now I'll share with you just a little bit about my postpartum experience with multiple sclerosis. I was quite nervous. I had heard a lot that there was the potential to have some flare-ups after having a baby, and so I prepared myself as best I could. I lined myself up with a lot of friends and family. My mother came to stay with us for a while. I got a lot of support because I wanted to make sure that I would be able to not only care for my new baby, that I would also be able to care for myself. So one of the other things that I did was I found a gym that had a daycare. And I was actually really lucky because my husband's cousin was the daycare provider, so I felt very comfortable leaving my daughter with her, and actually was able to start going to the gym when my daughter was just 6 weeks old. And that really had a big impact on my physical health, on my mental health, and I really think was something that was able to help me through those first few weeks and definitely through my whole maternity leave and postpartum experience. I was able to have a daily fitness class. I was also able to have an hour away from my daughter, who I love dearly, but I also really needed to have that time for myself. I had heard a lot about sleep deprivation and how stressful that can be, how difficult it can be to have a newborn, and also how hard that could be on my MS. So I really took to heart the fact that I should sleep when my baby slept. I took a lot of naps. Often I would sleep with Clara-Mae on my chest, and I was able to keep myself as well rested as possible. Another thing that I felt was really, really important for me, and I try to show it in the picture on the far right there, was laughter. And I'd heard a lot about how challenging it can be to have a newborn and how stressful it can be. I hadn't heard a lot of people tell me how much fun it could be and how absolutely hysterical newborn babies can be with all of the things that they're learning and their different facial expressions and the different noises they make. And so I actually laughed a lot when I was on maternity leave with my daughter, and started doing some research into the health benefits of laughing, and actually became a laughter yoga, actually got my laughter yoga leader certification. I didn't even know it existed before maternity leave, and went out and did that on maternity leave, and it actually made me feel really, really good. And I would say, and I still say to this day, I would say that year after I had my first child was probably the best I'd felt in years, certainly the best I'd felt since I'd been diagnosed with MS. So I did breastfeed my daughter for 6 months, and only 6 months because I wanted to get back onto the Copaxone. So I got back onto the Copaxone after 6 months, and then lo and behold, I got pregnant again very quickly. Again, also extremely lucky in that fact. So when Clara-Mae, my first daughter, was 9 months old, I became pregnant with my second child. I did go back to work for a little bit, and this time I was smarter about it. I still had a demanding job. I just had a different perspective on things. I wasn't sweating the small stuff. I wasn't working as many hours. I changed jobs so that I didn't have to spend as much time in the car. I kept my physical activity up. I kept my laughter yoga up as much as I could, and I really learned to not sweat the small stuff. I I also kept my laughter yoga up, as I said, and actually I was at a conference with about 200 people doing laughter yoga when I was 8 months pregnant, and I think they all thought that I was going to go into labor there, which was probably pretty funny. My pregnancy with my second child was much better. You can see on the left-hand side there's a picture of me and my daughter Clara-Mae. The picture in the middle of me was when I was actually about 7 months pregnant. So I felt a lot better with this pregnancy. I think I looked a lot better too. I gained weight, certainly, just in a different way, and I think carried it a little bit healthier. And then the picture on the far right-hand side is actually me at the MS walk. I was 39 and a half weeks pregnant at the MS walk, and I did the whole 5K walk and actually went into labor that evening. So if anybody's looking for a way to go into labor, I would suggest a long walk. So went into labor that night, as I said, and the labor also, even the labor was much easier with my second child. And my second daughter, Victoria, was born on May 3rd, 2016, so 18 months after my first child. I was really, really lucky. One of the things that I would say helped with my postpartum experience with Victoria, and again, I prepared myself because I was worried about having an MS flare-up, was I was able to keep Clara-Mae, my first daughter, in daycare part of the time. And that was really helpful for me because, again, then I was able to get back into that rhythm of napping when my baby napped. If I had an 18-month-old at home, I may not have been able to do that. So I was really conscious to make sure that I wanted to keep my sleep. I also kept up the gym, so I kept going to the gym. I kept going to the same gym, and I was able to take my daughter there. Again, it was so helpful for me to have a gym with a daycare. I kept doing that. I kept up the laughter yoga. And in fact, during my second maternity leave, I went and got my certification to become a fitness instructor. So that was also something to sort of encourage me to continue staying physically active if I was able to actually teach classes as well. So again, with Victoria, my second daughter, I breastfed her and planned to breastfeed her for only 6 months so that I could go back onto the Copaxone again. She was a little bit more stubborn than my first daughter. Excuse me. So we ended up breastfeeding her for 8 months and then went back onto the Copaxone after that. So now, that brings me to now. My girls are 4.5 and 3. I'm still doing quite well. I've had a couple of flare-ups since, nothing that I would say would be too serious. I have had to go on to a new medication. The Copaxone I was on for about a year after my children, and then my next MRI did show that there had been some progression in the disease while I'd been off meds during my pregnancies and breastfeeding. So I did go on to a new medication. I am feeling good. We've decided in our family not to have any other children. We have 2 fabulous girls, and I count myself very, very lucky to have had 2 healthy pregnancies and have 2 healthy children out of it. And really, I would say it's as much as it helped me learn to take care of others and learn to take care of children, it really helped me understand the importance of taking care of myself. So I've continued, as best I can, keeping up my exercise, keeping up my eating well, and continuing with my laughter, because I found that those have really been the keys to keeping myself healthy and to keeping my family healthy. So that's a bit about me, and with that, I think I'll turn it over to Jillian to open up the floor for questions.
Thank you very much, Rebecca. Thank you for sharing that with us. I always love to hear sort of the personal side, of the real life side of one individual with one diagnosis. I realize it's not the same for everyone, but it's always wonderful to hear from that perspective. So thank you so much. As Rebecca said, it's now time to open the forum up to questions, and we have a bit more time than expected, so that's lovely. I just want to remind you that there's a couple of ways in which you can ask your questions to either Dr. Sadovnick or Rebecca, and that is through the chat pod. So you can press, basically unmute your own line by pressing *7, and that way you can ask over the phone just like I'm talking to you right now, or alternatively, you can ask your questions through the chat pod. You can just type away in there, and I'll sort of ask, I guess, on your behalf. And I just want to remind you that only the presenters and I can see the question you've posted in the chat pod, and we won't say your name. So there is a little bit of anonymity that comes with that. And if you can just indicate who the question is for in the chat pod, that would be lovely. I also want to take a moment to let you know that we do have with us also today an MS navigator. Dawn Young is also on the line. And as an MS navigator, Dawn is able to use her knowledge and past experiences as a community resource coordinator for the MS Society in Saskatchewan to help those affected by MS navigate the many resources that are available and enabling people to enhance quality of life while living with MS. So if you have any specific questions with respect to the services provided by the MS Society or other resources that are available or might be available to you, then Dawn is on the line to take your questions as well. And then finally, before I jump into the first question, I just want to make a note that I'll be posting some poll questions during this Q&A portion. And I invite you all to take part in answering all 5 questions before we leave the session today. Your answers are anonymous, but they help us tailor future webinars to meet your needs. And you just have to take your mouse or your cursor and click on the one that suits you best and hit submit. And so each question will be up there for a couple minutes, and then we'll move on to the next question just as we're going through with the Q&A. So I hope that makes sense to everyone. Okay, so we have lots of questions coming in, which I love. So bear with me here. I'm just going to get started on the first one here. Perhaps I'll direct this to both of you, and have your perspectives shared with the group. And this person is asking, she says she really needs some help in how to talk to her neurologist about trying for a pregnancy. She's been pretty much told no with respect to having kids, and she says she's 40 in 2 weeks, and the clock is running out. So she's hoping for some direction on that. So maybe from each of your perspectives you can share sort of your thoughts about that.
Okay, it's Dr. Sadovnick. I think I would say that this is not a question that can just be answered online, because there are many factors that might be involved in this discussion. And I would be very happy if you wanted to contact me to discuss this with you offline, but I don't think it's something that we should be discussing now.
Rebecca, did you have any pushback at all from your clinicians, whether it be family practice or a neurologist, about or any concerns?
Yeah, a great question. Yeah, I mean, as I said, when I was first diagnosed, essentially what my neurologist said was, you need to make a decision. Are you going to go on the drugs now, or are you going to have kids now? Because if you're on a disease-modifying therapy, then you shouldn't be trying to get pregnant. So that was really the conversation that I had with my neurologist. And as I mentioned, sort of decided to go on the drugs to stabilize myself, and then felt comfortable moving on. So that was really the only conversation that I personally had with my neurologist about it.
Thank you. Okay, so we're going to keep going. Actually, Rebecca, I'll keep you on the line here. There's a question with respect to epidurals. Did you have an epidural with your second daughter, Victoria, as well, or?
Absolutely. What I tell people is, as I said, I was reluctant to have the first one because I didn't want to have the no feeling in my legs. I realized that for myself, and everybody makes their own decision, but for me that was silly. And the second one, as soon as I went into labor, I went into the hospital and said, I'm ready for the epidural anytime. So yes, I did have it with Victoria.
Thank you. Okay, let's see here. So I'll keep you one more on the line here, Rebecca, and then maybe we'll switch over to Dr. Sadovnick for a few questions. There's another question about what DMT drug, if you're willing to share, that you're on now, and how do you find if your symptoms have improved or differed since being on that particular medication?
Yeah, that's a great question. And those of you, probably most of you on the phone have MS, so you may experience brain fog, which is happening to me right now. I just can't seem to get the name of the drug. So give me a few minutes. Hopefully I will come up with it. But it is actually, it's a pretty exciting drug because I only have to take a few pills a year. So I take, 5 pills 1 month, 5 pills the next month, and then I take nothing for a year. So it's a significant improvement from the Copaxone where I used to give myself a daily injection. So I will, please give me some time. Hopefully my brain will clear and I will come up with the name of it. But yeah, I've definitely, I'm feeling very good on this drug.
Wonderful. That's great news. So we're going to transition over to you, Dr. Sadovnick, and actually this is sort of a nice segue. And we've had a few people ask about why, and I know you can't speak specifically, obviously, to Rebecca, but if simply having MS puts you as, or deems you as high risk for pregnancy, is that something, or does it depend on the thoughts of the particular healthcare provider? Is there a best practice for that? Can you speak to that at all?
At the moment, the best evidence we see is that just having MS does not put you at a high risk for pregnancy, and you do not have to be treated as a high-risk case. The physician should obviously know that you do have MS, but MS in itself is not high risk. It doesn't protect you from other factors, such as was mentioned, the gestational diabetes, but I don't really think you have to consider it a high-risk situation.
That's great news. So Dr. Sadovnick, I'll keep you on the line here. We've just had a few questions about your study in particular, and just asking a little bit more about, if you can tell us a little bit more about the study. If you sign up, how will you be followed? How long are you followed? This particular participant is 8 weeks along in her pregnancy, but if you can speak to sort of generally as well, that would be beneficial, I think, for most of us.
Okay, generally anybody who is planning a pregnancy or is pregnant at any stage can be involved in the study. When we get your contact information, either by email or on the 1-800 line, we will contact you, describe the study in more detail, answer your questions, and if you're still interested in moving forward, we will send you the official consent forms you have to sign. This is a university ethics requirement. Once you agree to participate in the study, and note that you can withdraw from the study at any time without any effect on your treatment or anything else. But once you decide to go into the study, you will be contacted probably by Maria by telephone, and the interviews will be at set times during your pregnancy, and once you deliver, it'll be at set times after you deliver. And after delivery, we will also ask about the baby's development. If there is a pregnancy loss, we want to record as much information we can as possible. And if someone is trying to get pregnant, they either contact us when they get pregnant, or if we have not heard, we will get back to them in 6 months and just keep checking what's going on. But it's completely your choice, and you can withdraw at any time.
Thank you so much.
Sorry, it's Rebecca. I'll just jump in. Yes, the drug is Mavenclad cloud release. Just came to me, and then I saw that you sent that. So yes.
Yes. One of our participants jotted that in. So thank you to.
Thank you, everyone.
See, it's a community, I tell you. Okay, that's wonderful. So, Dr. Sadovnick, I'll keep you on the line here, and that is, there's been a few questions come out with respect to the men's fertility and how, MS can impact male fertility specifically. Can you speak to that at all?
I can speak to it to some extent. Unfortunately, there's never really been a formal study done on male fertility. For obvious reasons, as you know, you can identify mothers, but it becomes more difficult to identify fathers. However, having said that, if a man is on a therapy that he wants to continue on or is about to start a therapy he wants to continue on that might have a risk to developing fetus, there's always the option of freezing the sperm. Also, once the child comes, the man can have as much effect by the lack of sleep and the chaos that goes on in the house as the woman who has MS. So these things have to be taken into consideration in the long-term planning. And I think for both men and women with MS, the biggest issue is don't focus so much on what you as a parent can't do. Focus more on what you as a parent can do. And I think the other presenter was very fortunate in that it sounds like she had a very good support network and availability to access to a lot of things. Unfortunately, this is not the case for everybody.
So that's actually a great segue, Dr. Sadovnick, because there has been a couple of questions with respect to potential concerns or complications for people who may become pregnant, whether it be intentionally or unintentionally, while they're currently on DMTs. This might be, this individual notes that obviously this might be medication specific, so you may or may not be able to expand, but are there any sort of general thoughts on some of the potential risks while on DMTs if you either become pregnant intentionally or unintentionally?
Well, this is a very hard issue that we're hoping our study is going to answer. In the past, as I mentioned, they used to have therapy-specific pregnancy registries. So if you were in a clinical trial, you had very special criteria to get into the trial. You had to have a certain amount of disability, a certain duration, a certain type of course of MS. So it was very specified who could get into the trial. And then you were monitored much more often than you would in the general population. Now we've really come beyond clinical trials, and DMTs are out there for the general population. And they're not scrutinized to such an extent. So we really don't know the answer. What we're trying to find out is, okay, there's the odd therapy that we know from other diseases is very teratogenic and you should not get pregnant. But for the majority of the DMTs, we really don't have evidence-based data on what happens if you're exposed at the time of conception or if you're exposed at any time during pregnancy. So this is what we're trying to find out. If you have to ask me my gut feeling, I would say that probably for the majority of DMTs, it's not going to be that harmful, but we have to wait and see. There's also controversy about the washout period. If you're trying to get pregnant, when should you stop taking a DMT before you start conceiving? But on the other hand, in our study, we've come across many people who were on a DMT and unexpectedly did get pregnant. So what we're really doing is trying to get the real-world scenario. You cannot jump from animal models strictly to humans because the doses that are used in animal models and the environment that animal models have is so different than what humans have. You also can't just look at provincial health data to see who's taking what drug and when and try to come to conclusions, because those data say who has a prescription, but it does not give you information if the person is really taking the drug, not taking the drug, etc. So this type of a prospective population study is, I think, going to be the way to go to really get some answers. And I really think that as we're moving forward, taking into account all the psychosocial aspects as well, the majority of women who we've come across who have had pregnancies have tended to do well.
Thank you. And speaking to that as well, Dr. Sadovnick, I'm seeing a few questions with respect to the actual MS symptoms during pregnancy, and some are reporting, that they've actually been felt really terrific while pregnant and haven't had any flare-ups or anything like that, and while others are saying that they were very symptomatic. Does it tend to be sort of dependent on the person, dependent on the pregnancy? I mean, Rebecca, I know you can speak to your particular circumstances as well for each of your two pregnancies and maybe mentioning if they were the same or different but generally, like, you know, overall, is everyone's experience probably unique, or is there some I guess consistencies when having MS and being pregnant in terms of actual symptoms and flare-ups?
There's really no consistency. And even with one woman, as you heard from Rebecca, one pregnancy can be more complicated than another pregnancy. So it's very individual, and it depends not only on the MS, but all the other factors that are around you while you are pregnant. So I'd like to say that everybody is an individual, and every experience is the best, is their own. We don't really know, even though literature has the odd case report, we don't really have any data to suggest that a pregnancy can change your long-term disease course, that if you weren't pregnant, you'd be doing much better than if you had a pregnancy. And it also, the number of relapses you've had before a pregnancy does not necessarily indicate what's going to happen in the pregnancy and the postpartum period. So it's really a chance, and it's a chance you have to be willing to take. And as Rebecca said earlier, one important thing she did, and I think a lot of people have to do that too, is plan ahead, plan for the extra support so that you're not overwhelmed, because I've had 3 kids, and I know what it's like having a newborn in the house, and it's chaotic. Mm-hmm. So a lot of things that happen aren't necessarily MS flare-ups, but it's just coping with having a baby who's not sleeping, not eating, difficulties like that.
Not to mention if you've had C-sections and that sort of thing as well.
Exactly. And that's also another point I think is so important, is that in management of the pregnancy, you have to have all the necessary screening and the monitoring that any pregnant woman has. If you need a C-section, you have a C-section. If you can have a natural delivery with or without epidural, that's your choice. If you need screening because of advanced maternal age or a family history or anything, you get it. You follow it like a regular pregnancy, with the MS just being one extra factor.
Right. If I could just jump in, it's Rebecca.
Yes,
it's interesting to hear you to hear the research behind things, Dr. Sadovnick, because I had heard, and I will admit I didn't do very much research before I got pregnant. I had heard, though, that your MS symptoms your likelihood of relapse or flare-up during pregnancy is a lot lower. And so that is what I'd heard. Again, maybe wasn't based in anything particularly fact, but for me, I think my MS certainly didn't act up, and maybe it was just because I was so focused on some other things. With my first pregnancy, as I mentioned, I was quite ill, and so I was more kind of focused on that than on my MS symptoms. And with my second pregnancy, I had an 18-month-old at home, so I was maybe more focused on taking care of her and taking care of myself and keeping the fitness. So interesting to hear, though, that there maybe isn't any scientific basis to say that, what I had anecdotally heard about your MS relapses being less likely during pregnancy, that there doesn't seem to be any scientific basis for that.
Well, let me add that a lot of that information originally came out of a study by Dr. Confavre in France. And in this study, you have to remember, it was done over 20 years ago. Most of the data were retrospective. That means people had to remember what happened. And if you're overtired and you feel very tired or discombobulated because you're exhausted, that's not necessarily an MS attack. Also, this was before we had the DMTs and before we were diagnosing MS at the earlier stages that we are now. So his paper, which came out at about 1990, stated that you usually tend to feel better in the 3rd trimester, and then with the change in hormones, you can have a higher risk of an MS attack in the first 3 months postpartum. But I think in today's world, that is no longer considered a general rule. And as I said before, each person has their own story. And that's another thing with this study, what we're trying to do is, in a non-identifying way, we are also keeping track of the stories people tell us, because we know there's more to finding out about pregnancy and MS than just looking at numbers and official data. And a lot of people are very happy to share their stories, what they think about to get pregnant, how they plan ahead, how it goes. It's very important.
Thank you so much. Your perspectives are so wonderful, and I love having both of you coming from it from different lenses and being able to share your learnings with us and teachings. We're going to keep going for the last few minutes here. This individual is touching on having trouble conceiving naturally and wondering if MS has an impact on fertility and how long they should wait to see a fertility specialist if they are having trouble conceiving naturally.
As far as we know to date, there does not seem to be any problem in terms of conception. Having said that, women are now getting pregnant at later ages in the general population, and I think difficulties in conceiving are more frequent now because of the age at which people are trying to get pregnant. So like any person who's trying to get pregnant, if you have problems and nothing happens within 6 months to a year, you should start talking to a fertility specialist. But there's nothing to indicate that males are less fertile, and there's nothing to indicate that females have more trouble getting pregnant on a general basis.
Okay, that's great advice. And now moving on to children. So this person has asked if children that you have, if you have an MS diagnosis, and if your children should be checked at some point, and if so, how often, if the parent has MS.
Okay, this is a very difficult topic because if you look at the general population, you look at about 1 in 500 people have MS. When you start looking into biological relatives, that's people who share genetic material, so that would be like a parent-child, the risk is higher. We're talking maybe 3% over a lifetime, which is still a very low risk. To put that risk into perspective, we're talking about a 3 to 4% risk anytime any woman gets pregnant just to have some problem with the pregnancy. So it's not an alarmingly high risk. There may be a few families where there's multiple generations of people with MS, but that's very rare. I would not encourage any testing of children unless they are showing atypical symptoms that are suggestive that a neurologist has to see them, because you do not have to monitor the children. One of the suggestions we have, of course, is the vitamin D and trying to make sure they have adequate vitamin D. But do not start giving children MRIs. Do not start bringing them to neurologists on a regular basis. The majority of children do just fine.
Thank you. I'm going to go back to your study, Dr. Sadovnick. There was a question for you with respect to postpartum follow-up and whether the baby is studied as well once he or she is delivered. I can't recall if you mentioned that or not when you were explaining it, so I just wanted to touch on that before we left.
Yes, we're definitely looking at postpartum follow-up because that is very important. And right now we have the funding to follow up to 1 year. I'd like to do it longer, but our funding right now is only till 1 year. And we do check all the milestones and look for infant development. There are a lot of gold standards out there for comparison, and we are very interested in child development.
Wonderful. Okay, so I'm going to do one more here, and I'm sorry I didn't get to everyone. I've done my best. This is having to do with labor again, and I'm going to do my best to combine these last two. One having to do with whether MS and muscle weakness in the pelvic floor, whether that helps to contribute to either a difficult or long labor, and two, if any research has been done on whether having an epidural impacts MS symptoms.
Okay, well, going back to the epidural, again, we are looking at that, but the past data and information that is in the literature does not suggest having an epidural makes any difference. The same way as it does not suggest that having a C-section makes any difference in terms of your MS. In terms of the pelvic muscle, it's no different than any woman. If you have weaker pelvic muscles, it'll be more difficult, but obstetricians are very familiar with that.
Thank you so much. So I'm just going to here, I'm going to throw back to this. There we go. Someone was asking how they can get a hold of you, so I just wanted to put this phone number and email address back up. So for those that are interested in reaching out to Dr. Sadovnick personally, then you can do so through those means. We are at 1 minute too, so I think we're going to have to hold it there. My goodness, what wonderful questions you all brought today. Thank you so much. It's always lovely to have such great interaction and exchange of information and ideas during webinars. So thank you all to our participants. And of course, I want to thank our presenters, Dr. Dessa Sadovnick and Ms. Rebecca Scott Rawn, as well. Dawn, we didn't hear from you, but I know that you're on the line ready and waiting if a comment came up or a question came up, so thank you for your availability as well. I just want to say two things before I turn it over to my colleague Jenny for final remarks. One is that a recording of the webinar will be available on the MS Society of Canada's website within the next week or so, and also too, it will be available on Brain Exchange, and you'll receive notification through email when that recording is available. So Jenny, any final words? Jenny is my colleague from the MS Society of Canada. Are you there?
Before Jenny talks, could I just add one thing? It's Dr. Sadovnick. I want to thank the MS Society because they have been very helpful by advertising our study on a regular basis on Facebook, and it's been very helpful to us, and we really do appreciate it.
Oh, wonderful.
Hi, everyone. It's Jenny from the MS Society. Thank you, Dr. Sadovnick, and we're glad that we can help support your study in that way. And I just hope that this webinar was also a good platform to get that out there to anyone who would be interested. And on behalf of the MS Society of Canada, we would also like to thank our partners at Shoppers Love You, who are a leader in supporting the health of Canadian women living with MS. We also want to thank Jillian at Brain Exchange for, as always, for moderating and helping to coordinate our education events. I just want to bring to light the fact that we have a Women's Health and MS book publication on our website. It's in our information library. So if anybody wanted to kind of get some more information on women's health and MS, that is available on our website. If you have any difficulty finding it, then please feel free to contact the Knowledge Network, and one of our navigators can help you out there. And I just want to encourage everyone who attended to please fill out the post-event survey. We really look forward to seeing your feedback, and it really just helps us to improve and develop this education session going forward. So thanks to everyone who attended, and enjoy the rest of your day.
Thanks, everyone. Have a great day. Bye-bye.